I would love to get going here. Um, Good evening, everybody. My name is Bruce Holmblad. I'm the Riverside County Medical Association president. We're here for our monthly call-in with Dr. Cameron Kaiser. I always like to thank Dr. Kaiser for his leadership, his foresight, and I know that I certainly feel safer, and I know my family feels safer for a lot of the tough decisions that he has had to go through as our public health officer. And without further ado, I'd like to introduce Dr. Cameron Kaiser. If you could give us a little update before we go through some of the questions that our members have submitted. Dr. Kaiser.
Thank you, Dr. Holmblad. Good evening and thank you. Today's numbers add 283 new COVID-19 cases and 1 new death for a total of 61,246 cumulative cases, 55,809 recoveries, and 1,248 deaths, with a current positivity rate of approximately 6% through October 1st due to the state 7-day lag requirement. As you have no doubt heard, our case rate, which has been continuing to increase, now exceeds the purple tier threshold in the governor's color tier framework, incorporating the penalty assessed upon us for not reaching the state median testing rate. Unadjusted, our new daily case rate 7-day average with a 7-day lag is 6.8 new cases per 100,000 population. With the penalty for the assumed number of cases yet to be detected, however, it is 7.6. In addition, you have also heard of the state's health equity metric, which seeks to ensure that counties do not progress through the tiers without attention paid to disadvantaged segments of their society. The most recent official state calculation for what we're calling the fourth quartile population, as defined by the Healthy Places Index, is a positivity rate of 7%. This number would have to come down substantially to 5.2%, which is to say, a small threshold over the 5% threshold to enter the orange tier for the county to progress further through the governor's framework. As I mentioned, while our case rate is clearly not going the right direction, one other note is we are also being penalized by inadequate testing. If we did not have the penalty, we would still be in the red tier. And this is one situation where business and public health interests align. We certainly understand why the penalty exists, or a county could just refuse to do any testing and have no cases at all. But the businesses don't want further restriction by moving backwards through the governor's framework. And certainly we in public health want to find cases and intervene upon them. So if we can eliminate that penalty, not only will this help our businesses, but it also means that we in public health and for the physician community will be looking at a truer picture of our county incidence. We continue to advocate with the State Department of Public Health to ensure that point of care antigen testing is incorporated into our numbers. But in the absence of that policy, the only thing that counts towards our metrics is PCR testing. If you are referring patients for testing through Quest or LabCorp or one of the large national clinical labs, those numbers are getting into our statistics because, as a condition of being licensed in California, they must support the electronic laboratory reporting system. However, if you are running point of care rapid PCR, such as Abbott ID Now, and as an aside, if you are, I'm actually impressed because it's very hard to get reagents for it. But if you are, then unless you explicitly send those to us, and we need both positives and negatives, then they are not in our statistics. We prefer an electric format. Something even as simple as an Excel spreadsheet would make our epidemiologists very happy. But if all you've got is a faxed logbook, that's better than nothing. Please contact me after the fact and I will get you plugged in. With that, Dr. Holmblad, I'll hand it back over to you for the questions.
Okay, thank you for the update, Dr. Kaiser. Question number 1, what does it mean from a public health point of view that COVID-19 can spread through the airborne particles, which can linger on even if one is more than 6 feet from an individual? A, mass treatment time then, or B, outside your home?
I'll say first as a parenthetical observation, we're almost getting whipsawed with the back and forth from the CDC on exactly what level of airborne spread actually occurs. And those of you, I mean, it seems like a lifetime ago when we were arguing about this, but months ago, the airborne versus droplet precaution spread came up and still circulates. Even though I think we do have good empiric studies which show that even if there is some airborne component to it, there is also clearly a droplet component, and surgical masks certainly will reduce that risk. Nevertheless, that being said, we have always adopted the view that facial coverings and social distancing and other preventive measures are reinforcing measures. They are not mutually exclusive. And other mitigating circumstances notwithstanding, 6 feet of distance does not replace having a facial covering. Facial coverings don't replace avoiding gatherings. Being outdoors doesn't replace any of them, and vice versa. And the governor's, I think one thing that's important here is the governor's face mask order requires a mask indoors of a public space, such as at work, and outdoors when maintaining a physical distance is not feasible. But I think we can say at this point this is not sufficient if from no other purpose than a public understanding view, because it causes people to believe that being outdoors is the part that's actually making you safe. And I think that people are getting the wrong idea about risk levels. As far as what is my personal practice as to what I'm doing, I'm wearing a mask anytime I'm outside of my house. Those of you who've seen board meetings show that I've gone great pains to make sure this is visible when I am publicly before them. I don't even remove it when I'm speaking to them for that reason. The mask protects me from others. The mask protects others from me, I should say, as I would like to be protected from them. And for the patients that I am seeing, I always thank them for using them. I think also inside your house with normal members of your household, assuming, of course, no exposures, nobody on quarantine, no situational risk changes, I think it would be reasonable not to use one in that circumstance. But I think that we should remind patients and the general public, it is the sum total of the precautions which enable us to conduct our affairs safely, and not any one safety practice over any other one.
Okay, thank you. Question number 2. Now that Riverside County is in the red tier, what is the current status of school waivers? Is it only for elementary schools? Are any middle or high schools meeting in person? How are you monitoring whether the schools are following their submitted guidelines?
The waiver program was developed specifically for transitional kindergarten through 6th grade based on the assumption that the kids under 10, this was based on that large South Korean study, some of you will remember, were less effective transmitters. The Indian study, which came out in Nature very recently, is starting to throw that into a little bit of dispute because it showed that school transmission was actually a fairly important means, and that it was something like 18% of pediatric cases spread it to their peers. That cheering bit of news aside, per state guideline, once the county has entered the red tier for 14 days, and we hit this threshold on Tuesday, schools may, not must, but schools may reopen. And that includes all grade levels from transitional kindergarten through grade 12. This essentially suspends the waivers program because a school doesn't need a waiver anymore, at least not for the remainder of this period. And our schools unit would then move into an advisory role to offer technical advice to schools which are trying to construct their reopening and safety plans as they're required. We are aware of at least 1 or 2 private schools who have already completely reopened all grades. They are allowed to do that. I'll talk a little bit about the enforcement bit in a second. We have not heard, though, of any public school systems which are planning to do so, although on our weekly schools call on Wednesday, we did hear that there are a couple of districts who are considering it, but they're also keeping in mind the changes to our local epidemiology. Now, with regard to enforcement, during the waivers period, we periodically checked in with schools. That is part of the condition of the waiver which I required from them. And by the way, if you're ever curious to see exactly under what conditions the waivers were issued, those are all public documents and we posted them. Complaints that we received, and we certainly got some, including some with pictures, and that's pretty hard for the schools to ignore. I forward these on, and I personally did that myself because the enforcement mechanism is coming from me directly, and I required remediation from those schools where those issues, I believe, were actionable. Now, I want to make clear a couple things, though. Our experience at the waiver school is likely to be very different in that there was a very small number that I directly supervised, and I had the ability to withdraw their waiver at any time, and I regularly reminded them of that fact. I don't have that control mechanism, at least not right now. As of the remainder of this week, the California state guidance is such that schools don't need my permission to open. And the vast majority of schools that opened were private schools. We had a couple charters. And these are schools with smaller enrollments, usually from higher socioeconomic levels. That means parents are less likely to be essential workers. They're less likely to be exposed, and in turn, they're less likely to bring it home and expose their kids who would expose others at school. But that said, I do expect cases to pop up in schools. We did have some. You didn't hear about them much, though, because those cases were contained. The most important predictor of school transmission is community transmission. And we're clearly beyond the point a few months ago, which in COVID-19 time seems like years, where a single suspect case would have shut down a school. But any school that chooses to open during this period, they're going to need to give a great deal of thought to their operation. The purpose of the school guidance is to give them that framework to limit spread by social distancing, facial coverings, the appropriate hygienic precautions, and to limit those who need to be quarantined to those smaller cohorts so that other students are less affected and therefore less at risk. If they do this, they should be able to contain a case or even a couple in various cohorts, with the assumption, of course, they don't hit any of the CDPH triggers, such as 5% positivity in a school or multiple cohorts hit, where it is recommended that I would step in as health officer. As such, if we get an actual confirmed outbreak, and the state usually uses a minimum threshold of 3, in a school setting, that would be of relevance to the community and would certainly prompt scrutiny of their procedures. And I told the schools, and we have this weekly call, and we've had them, I've tried to attend the last several weeks because of a lot of the questions about how the school reopening process works. I told them that if an outbreak happens, despite them taking good precautions, you know what, I'll call it as I see it. Sometimes stuff happens. But if it happens because they are not taking the appropriate precautions, we're going to make that call too, and I'm not going to defend a school that lapses. And that, besides the fact that that's not a nice thing to have out there in public, it has real impact to their liability if legal action were ever taken against the school by a parent or a staff member. And frankly, I think that may be a more effective means of getting their compliance than any direct action I could personally take, especially under the circumstance given that the CDPH thresholds for closing a school are relatively high. Now, if we happen to return back to the purple tier, I know that's the next question, but I'm going to answer it as part of this one just to close the loop on schools. If we return to the purple tier, any school that is currently open at that time may remain open. But any school that has not opened during the period we are in the red tier then must seek a waiver, and the waiver would still be limited to TK through 6.
Okay. Question number 3. I think you kind of answered it a little bit. Our positivity rates, unfortunately, continues to climb. Do you feel Riverside County will move back to the purple tier in the next week or so?
My crystal ball has gotten an awful lot cloudy during the last several months, and I never want to say never, but I will say the trend is probably against us. As I've mentioned before, the state statistics do intentionally lag by a week to let the cases come in and fill the buckets, essentially. So the numbers that we are getting now are really last week's numbers. If either our case rate or our positivity rate go back into the purple tier, and it's either one, and they do so for 2 weeks, we go back to the purple tier, and we have one bad week of numbers already. So even if we did intervene this week and did everything right, we would still have 2 weeks of potentially purple tier numbers because those numbers will be from the week we didn't intervene. It's not a guarantee that we're going to be there, but I think it is a significant probability. The small light here is that the one statistic that does not lag is testing rate. And I remember that I mentioned that it's the testing rate penalty that's pushing us into the purple tier. I mean, I don't want to make light of our number. 6.8 per 100,000 is still at the upper edge of red, so don't get the wrong idea from me saying so. But what's clearly making us purple from that is the penalty which is assessed from us not testing at the state median. That is why we are making such a push for testing this week, so at least we can cut that particular penalty back. Just to add on to this, there is an argument for asking for a 4-week move back period so that if we made a change, we would have enough time to observe it. But given that the governor, and I'm sure those of you who saw the press conference on Tuesday will remember this, the governor's already moved 2 counties back already. Both Shasta and Tehama counties got moved back to the red and purple tiers respectively. So at least into the next week, it is pretty unlikely there will be much change on this policy in the short term.
Okay. Question number 4. Many organizations are evaluating when they can return to having live events for a large amount of people indoors. Do you think it is feasible to consider having an indoor event for 200 to 250 people in January of 2021? What are the current requirements under each of the tiers?
I wouldn't have any idea what this event is possibly referring to, so I will simply speak hypothetically. Hypothetically, if such an event were to be planned, I think that if the flexibility exists to wait and see, I would strongly recommend doing so. We really don't know what our numbers are, and as it stands right now, it's not really clear to me whether we're at the cusp of an actual increase or we're just at the tail end of a blip. Because remember, we came off of Labor Day. That was a few weeks ago, so I'd expect that all to clear, but it's remarkable that LA and Orange County were still seeing some case numbers filtering in, so it wouldn't be surprising to me if some of that occurred. And remember that all of the models predict an increase in COVID-19 cases this fall and winter. As the old expression goes, all models are wrong, but some are useful. And while they disagree on the timing and the magnitude of the rise, I think they all agree that there will be one. One other consideration which occurred to me earlier today is also the public perception of holding such an event, especially if the event were to be represented by, shall we say, a leadership sector. And this may weigh into this as much as any other consideration. I don't want to say definitively that I would steer clear, but I do note, and since the question specifically asked about tiers, none of the tiers per se speak about any large events specifically, although, as I mentioned, the board action, and that's the subject of the next question, directed us to work with the state about that. At minimum, I would certainly wait to get more data on the table before moving forward because we are still in a very uncertain period.
Okay, thank you. The last question, question number 5, and then if you do have some time, we have some questions in the chat room also. So question number 5, the County Board of Supervisors were considering breaking away from the state tier requirements and having more lax requirements. Could you update us on that? What is the status of that?
The official board motion from Tuesday voted to advance the plan which was proposed by Supervisor Hewitt, but without specific timeframes, and to work with the state on guidance for wedding receptions in the tourism industry. Now, I note today that you may have heard that the theme parks guidance dropped from the state as well. So this should give you an idea of what guidance for those sectors is likely to look at and the tier in which they're likely to occur, since especially for tourism, there would obviously be some overlap. The plan as it stands right now for the stage that we are currently in is the same as the red tier, and no additional sectors in that first phase have been reopened in violation of the state framework. So as of this moment, right now in front of you, there is no breakaway. If we re-enter the purple tier, then the question comes into play about what does apply. And that would actually really be a call for the county council, because this would occur on a day when there is no board meeting, because it's a county holiday on October 12th, and the Board of Supervisors meeting is historically dark on days following holidays. At least for right now, per the minute order and the transcripts, and believe me, I sat down with the video about an hour to figure out exactly what motion they passed. The board policy, as the interpretation goes from the clerk of the board, is to remain with the red tier requirements, at least as of this moment, with the addition that staff will work with the state on guidance for those other sectors. More than that, I think that's about as much as I could say about it until we get more information.
Okay, thank you. I do see there's a question number 6 here. How often should an individual get tested to help lower with the positivity rate?
Well,
or
for
should
certain,
you only test once? I'm sorry, I didn't mean to talk over you.
that's right. Well, the answer to that question is if you test positive, I would prefer you don't be testing positive, don't be testing again, for the reason that people are going to be shedding junk RNA for a long period of time. But if you test negative, remember that there are certain classes of workers who are required to be tested as a condition of their employment. Right now, those classes of workers are primarily people working in high-risk settings such as skilled nursing facilities, LTCF, stuff like that. And also, for those schools which are open, teachers and staff. In fact, the school guidance from the state currently requires that the entire staff and teaching population of a school which is open be tested every 2 months. Similarly, skilled nursing facilities also have a regular testing requirement, and as long as you test negative, that is considered to be part of the testing surveillance because we will be able to detect cases that way, and the state will incorporate that into our metric. So you want to get a swab stuck up your nose as much as you like, please do so. We are more than happy to incorporate those numbers. But like I mentioned back at the beginning, antigen testing is not currently counted as part of this, even though we are trying to get the state to budge on it, because clearly for point of care testing, antigen is just much more convenient. Even though it has a false negative problem, particularly for asymptomatic people, for a surveillance testing strategy where you might be testing somebody weekly or possibly even more often, you're probably going to detect those cases anyway, and antigen testing probably still has some value there. Similarly, for rapid PCR, that also counts. And obviously, if you go and get a test in any of our county sites, or you do PCR, conventional PCR with either mid-turbinate or nasopharyngeal sampling, that obviously counts. That would consider to be the gold standard. I just saw somebody pop up saliva testing. That would depend on the modality. If it happens to be antigen, that currently does not count, even though we're trying to change it. The one testing modality, and I know this won't be a surprise to anybody on this call, but the one testing modality that does not count under any circumstances is antibody testing, because we cannot use that to determine if somebody is currently infectious. IgM levels just don't rise soon enough to make that useful for that purpose.
Okay, thank you. Do you have time to answer some questions in the chat room?
Yeah, I got a few minutes.
Okay, thank you, Dr. Kaiser.
The first one, it looks like, how can these airborne particles last in the air in the indoor environment? I'm not sure if that was how long or something like that, so I'll try and answer it both ways. We don't, the argument is over the size of the particles themselves. I still think, and there's still good evidence to suggest this, but again, like I say, the CDC is kind of whipsawing us on the recommendations. That droplet precaution is probably more significant simply due to the sheer numbers. I mean, you really do need an infective, a substantial infective dose to actually get sick from this, and a single virus or two is unlikely to be of much interest, whereas you could well have an infective dose from a large droplet spray which somebody happens to cough or sneeze around you. We don't believe that they last an especially long period of time, but if you look at other kinds of droplet, let's take measles, I guess, as a good example, that may be a couple of hours actually to remain in the air, depending on how quickly air was moving, whether there's a ventilation system, whether it's blowing it around. I don't interpret that as saying that your washout time for a room after somebody who's been contagious in there should be 2 to 3 hours. If you're going to be in somewhere, particularly in a healthcare setting where you're generating aerosols, especially in a bronchoscopy suite or something like that, you should be in negative pressure anyway, and everybody should be in N95 masks to deal with that possibility. But I think in ordinary community settings, and certainly in outpatient offices, even for ill patients, as long as they're wearing their masks, and everybody should be wearing a mask, particularly in that setting, I don't think that the amount of particles given off in a typical exam room is going to be enough to exceed the infective dose, at least for the vast majority of cases, except for somebody who is severely symptomatic and clearly discharging a lot. The next one, recommendations for flu vaccinations for a patient recovering from COVID-19. They should be completely recovered before you go ahead and administer the flu vaccine. The CDC mostly has adopted this position from the perspective of infection control. They don't want somebody who could be potentially communicable showing up at a flu shot station and then potentially infecting everybody who happens to be there, who would presumably be medically vulnerable because they're there getting their flu shot, even though everybody should be getting a flu shot, of course. Therefore, the recommendation is they should recover, at least as far as a 10-day, 24-hour rule. They certainly don't need to be retested and you certainly don't need the test clearance requirement. But I would certainly wait for them to get better before they went and got their flu shot. To the next question, who will be administering the vaccine when available? Probably anybody we can get, depending on how much we have. Now, so to talk briefly about the vaccines, I know Tony Fauci was talking that there may be enough spread in the U.S. so that we would have potentially phase 3 data as soon as October. I don't consider that to be good news, because that means we have so much spread around that we're actually doing a really good phase 3 trial by seeing if anybody gets sick from it. That's not really a good thing. But if the data was solid enough from that particular circumstance, then you know what? As far as I'm concerned, the vice presidential debate notwithstanding, if the phase 3 data is good, I'll be rolling up my sleeve. And I think that it would be incumbent upon all of us in the physician community, if we believe that data to be solid, to be doing the same. But once we do get to a point where we have sufficient vaccine where we can do a large-scale community rollout, at least at the beginning, it is likely to be done by the health department or by our contractors. But as the number increases, we would probably be deploying it into those areas where the high-priority populations happen to be. There is some talk, for example, of making sure the disadvantaged areas of the community, because they are disproportionately affected by COVID-19, would be priorities. That may mean that we may deploy some of this to CHCs, FQHCs, stuff like that, groups that would be working specifically with those communities. We would probably expect that those healthcare facilities to administer it to their workers, and we may work with them as well. So the answer to that question is all of the above, but not at all at the same time. And that will, of course, depend on how much is available and under the storage conditions required for doing so. Saliva testing, I answered. Would antigen testing qualify for school testing? The answer to that question is I have allowed that. Because I realize that there is a logistical issue with the schools trying to set up PCR testing, and we've tried to get schools used to the idea that once the CARES Act money dries up in December, regardless of what the board ends up doing as far as their plan or not, because remember that there was some discussion over what that would deal as far as our realignment and CARES Act percentage. Putting that aside, let's say that everything goes as planned, and we continue to receive our CARES Act allocation up until December. On December, the money spigot turns off, and that's the end of that. For that reason, we have told the schools that they need to have a testing strategy in place to make sure that they can continue to do whatever testing interval is required by the state. Right now, it is every 2 months. To make that burden on them easier, and because I personally believe that antigen testing will become more commonplace simply because it is much more straightforward to deploy and run that test. Therefore, I'm perfectly fine with the schools doing it. And as the testing frequency likely increases, to recognize that antigen testing does need a greater frequency to be more clinically useful. And given the fact that antigen testing is a lot more easy to arrange, I suspect that we'll see a lot more of it in school. So I have allowed them to do that. I am not aware of any that are currently doing it now. But as antigen testing becomes more commonplace, as long as it is an approved assay and they're following the requirements and it's something that can be done in a CLIA waive setting, I've let them do it. Finally, the last question, how many number of additional tests you need to avoid penalties? It is a 7-day average. Let me go pull up my state worksheet here, which I live and die by. The state currently has a median. Now, there's a theoretical argument here that if you're testing the right number, then you should be testing the right number no matter what other people are doing. The recognition that the state is making by using a state median, which is the median of all county testing, is that the state doesn't really know what that number is yet. But they think that everybody should be at least above that median. Now, as the median moves up, then it's possible that they're going to have to reassess. But currently, right now, the state median testing rate, which is updated on a monthly basis, is 216.35 tests per 100,000. That's a 7-day average with a 7-day lag. But the reason why I'm saying we're pushing for this now is if we can show that we're getting a lot more testing in there, there is an adjudication process which will enable us to move that data further along. Currently in Riverside, and this is a lagging indicator, we have 158.6 per 100,000, so we're a bit low under it. We would need to get the equivalent, remember that's per 100,000, so multiply that number by 2.4. I'm sorry, by 24, I'm sorry. we would need to get an additional number of tests per day, somewhere in the ballpark of, getting out my calculator, so in the ballpark of about another 1,500 tests a day to be comfortably above it. That's not a unreasonable number to achieve. I think we can do that, but we need to do so on a consistent basis over that period of time to make sure that we do so. And then armed with that number showing that we have made that increase in testing, we would then hopefully be able to present that for the state to see if they would consider this as part of the justification for keeping us in red a little bit longer. And I don't see any other questions.
Dr. Kaiser, thank you very much for spending time with your colleagues again. And once again, on behalf of the Riverside County Medical Association, I want to thank you very much. Good night, everybody. And thanks again, Dr. Kaiser.
My pleasure. Thank you. See you next month.